Good afternoon, everyone. Okay, this session I will talk about the digital tomosynthesis. First of all, I will start with what is a digital tomosynthesis. It's a type of limited angle tomography that provides continuous coronal images through the area of interest. As you see, the detector position was fixed, and the X-ray tube is performed a vertical continuous movement from like a minus 17.5 to 17.5 around the standard orthogonal PA position. And the result is going to be in the coronal section image without overlapping and allow the clear view of lung parenchyma, increase the conspicuity of pulmonary nodules, and provide greater sensitivity. This I'm going to show, this is like a from the front to back, like we score the CT scan is coronal, and we can see that, okay. And this going to be like a comparison of chest X-ray, digital tomosynthesis, and low-dose CT. Yeah, you can see that this can see the lesion clearer than chest X-ray. Now let's see what about its accuracy. There is a systemic and meta-analysis review of digital tomosynthesis and chest radiography, and use a standard as a CT chest as a standard reference. There are 16 eligible study evaluated and found that digital tomosynthesis have a poor patient-based sensitivity as 85%, and specificity is 95%. Compared to chest X-ray, the pool is just 47%, and specific is 37%. Now move on to how about the lung cancer screening with chest digital tomosynthesis. Okay, let me share about our experience on this one. We launched our integrative cancer screening project since 2012, 1 year after NRST launch that it can reduce lung cancer mortality. At that time, we see about compare between Thailand and America. Let's see, we have like we much poorer. And life expectancy is lower than about 5 years lower than America, and the expense on health capita is 14 times lower, and for the expenditure for health as a GDP is about 4 times lower. The prevalence of smoking in men, we have higher, but much lower in women. But the lung cancer incidence, let's say in men, is just lower than men. I'm not sure, maybe have some under diagnosis or not. Yeah, and lower in women rate. And lung cancer mortality, is. And we also have the prevalence of TB much higher than America. So at that time, our objective is to determine the role of lung cancer screening using low-dose CT in high-risk population of endemic area of tuberculosis, such as in Thailand, and also study the alternative screening modality, as you see. At that time, as we know, the benefits is to reduce lung cancer mortality, but low-dose CT itself have like some limitation, like high false positive rate, 96.4% from NRST. And at that time, we still think about how about the accumulated radiation dose and also high cost. And another one is some anxiety from positive tests. And digital tomosynthesis, the evidence at that time showed that with the nodules 6 millimeter at least is have sensitivity 100%, and specificity is by low-dose chest X-ray is just around 77 for the nodule 6 to 8 millimeter. And when the nodule is lower, like lower than 6, is just like 90%, and less than 4 millimeter is about 85%. So let's say it's good to detect the actionable nodules, but the much lower, the too small, tiny, we don't need that accuracy that much. And also the benefit is have a lower radiation dose, is around 10 times lower, and also lower cost than our low dose CT. So that time we launched the study screening lung cancer by low dose CT, digital tomosynthesis, and chest radiography. That time, because when we make a digital tomosynthesis, we're gonna have one chest X-ray automatically. So we combine 3 of them. So our inclusion criteria is 50 to 70 years old, much lower. It's a 5 year lower than in our ST that time, because we have a lower expectancy than American people. And we are the other cigarette smoker and farmer is the same as in our ST. Our exclusion criteria, we exclude the OTB or active TB in 1 year and some pneumonia infection. Recent 12 week, and people participant will do chest X-ray digital tomosynthesis at the same day. But when reading, the radiologist will read it blinded 1 week apart to reduce the recall bias. And our protocol, we use the low dose CT at the baseline, every cases, and also DT. But when follow up, we use like a annual digital tomosynthesis and do every 2 years of low dose CT in case that have a normal normal low dose CT. But those who have abnormal CT, we're gonna follow up as their category, but at least 1 year. Let's see, we have like a normal and abnormal. Abnormal, we have like a negative. But negative, we do look at benign characteristics, and also we add from the nodule protocol at that time. They just focus on nodule, but we add information into our protocol to see about tuberculosis as well. And we have the indeterminate nodule and suspicious nodule that, okay, I didn't get into that detail. Let's see if the category nodules is no nodules or benign nodule follow up 1 year. If suggests inflammation, we're gonna work up for TB and bacterial infection and treat cover and aerobe and follow up 8 week. If it's progress and have symptom, maybe to work up about infection. If clinically important, if CAT3, the indeterminate, we're gonna follow up 3 months and positive multidisciplinary team assessment. This is our result. Our N is just quite small, it's 634 for the high risk smoking, high risk smoker. But for the test follow-up, we found that total of lung cancer at baseline is 9 cases. And for low dose CT have a positive test, 22 cases, and DT 20, and chest X-ray 17. And sensitivity of low dose CT and DT is the same, 77.8. And while chest radiography is only 33.3%, and specificity is quite good for all 3. The positive predictive value of DT a little bit higher than low dose CT is 35, and positive predictive value is 31.1, and CI is lowest is just 17.6. And let's see when we follow up with you can see that for the total, we can get like a total lung cancer, the rate is around 0.8%, and stage 1 is 50%. stage 2 is 18, stage 3 is 2.1, and stage 4 is 22.7. And we also found that tuberculosis, even we exclude those that already know TB, we can get the new cancer, new TB, and new TB is a 0.5% for the first 2 years, and then it's lower in 0.4 and 0.2. For lung cancer, we got like as the baseline, we see is much higher than in Nelson, and in LST at that time we found is 1.4%, and at a follow-up, incident is 0.7 in the first and second year of follow-up. So you can see that in Thailand, we had a high incidence of lung cancer and pulmonary TB. And when compared to the stage 1 lung cancer, compared to others lung cancer screening, randomized control trial, let's see our is a stage 1 is 50%. That is comparable with other screening, and a little bit higher than Nelson that use interval at baseline 1 year, 2 year, and 2.5 interval. So we can see that the combination of annual DT and biennial low-dose CT protocol have a similar proportion of stage 1 case as other trials. In conclusion, the digital tomosynthesis is a lung cancer screening modality that's comparable to low-dose CT, particularly for pulmonary lesions 10 mm and larger in diameter. Chest X-ray was far inferior to digital tomosynthesis and low-dose CT for lung cancer screening modality. In countries that has limited resources, digital tomosynthesis may be useful as a screening tool for lung cancer screening. Thank you very much.